How to diagnose pulmonary embolism and DVT. Another important topic for PLAB 2 SimMan stations. In this video, I will discuss key points to remember when suspecting pulmonary embolism and DVT in a patient. So let's go straight into it. Typical presentation of pulmonary embolism is shortness of breath and chest pain. First step is to see whether this patient is in low risk category or high risk. Important points in history are that if there is no hemoptysis, no history of surgery or trauma in the last 4 weeks, no history of previous blood clots, no history of estrogen use, and age is less than 50, patient's heart rate is less than 100, oxygen saturation is more than 94% on room air, and there is no leg swelling, then this patient is in low risk category. In such patients, no further testing is needed. But if these factors are present, these findings are present in any combination, especially a positive history and heart rate more than 100, oxygen saturation less than 94% on room air, or any suggestion of deep venous thrombosis, then this patient is high risk patient. In this patient, we need to do probability testing by Wells score followed by appropriate imaging. So if patient is having high risk of pulmonary embolism, then we have to calculate Wells score. If Wells score is 4 or less than 4, then pulmonary embolism is unlikely. In such cases, we do D-dimer test. If D-dimer test becomes positive, then CTPA is performed to confirm pulmonary embolism. And if D-dimer test comes back negative, then pulmonary embolism is excluded. Important thing to note is that a D-dimer of less than 750 microgram per liter does not rule out pulmonary embolism in those patients who are at high risk. In patients where Wells score is more than 4, pulmonary embolism is likely. So in such cases, arrange further imaging to confirm the diagnosis. And these include CTPA and VQ scan. CTPA or CT pulmonary angiography, this is the first line test, CT with radio contrast. Its advantages are that it is accurate, non-invasive, it's more often available, and may identify other lung disorders as well, and can be used in pregnant women. If CTPA comes back positive, then pulmonary embolism is confirmed. If CTPA test comes back negative, then more tests are needed to exclude pulmonary embolism. Coming to VQ scan or ventilation perfusion scan, it shows that some areas of the lung are being ventilated but not perfused with blood due to obstruction by a clot. VQ scan is used for those patients who are allergic to the contrast or have impaired renal function, or in pregnant patients. VQ scan is preferable in these patients due to its low radiation exposure as compared to CTPA. There are other useful tests which you can perform in cases where you suspect pulmonary embolism, but these tests are non-diagnostic. These include chest X-ray to rule out other causes such as congestive heart failure and a rib fracture or pneumothorax. ECG primarily is done to rule out myocardial infarction. The most commonly seen ECG abnormalities in pulmonary embolism are sinus tachycardia, right axis deviation, and right bundle branch block. It may also show signs of right heart strain or acute cor pulmonale if large pulmonary embolism. It may show the classic S1Q3T3 pattern, which is a large S wave in lead 1, a large Q wave in lead 3, and an inverted T wave in lead 3. Blood test, which you can perform a full blood count, clotting status, PT, APTT, TT, and ESR, urea and electrolytes, LFTs, and troponin levels. Remember that troponin levels are increased in between 16 to 47% patients with pulmonary embolism. Some other tests, ABG, it most commonly shows hypoxemia and hypocapnia, that is respiratory alkalosis due to hyperventilation. But keep in mind that despite these classic findings, arterial blood gas analysis alone is not useful in diagnosis of pulmonary embolism. Leg Doppler is another useful test in this setting. The main use of leg Doppler is in those patients who have clinical symptoms suggestive of a DVT. and then echocardiography in massive and submassive pulmonary embolism and dysfunction of the right side of the heart may be seen on echocardiography. Now coming to deep venous thrombosis, how to diagnose DVT. As you know that presentation of DVT can be cough or leg swelling, dilated superficial veins, tenderness to the cough, particularly over the site of the deep veins, edema and color changes to the leg. If you see these type of findings in a patient and you suspect DVT, then next step is do probability assessment by Wells score. If Wells score is 2 or more, DVT is likely. There is about a 28% chance. So go to leg Doppler to confirm DVT. And if Wells score comes less than 2, then DVT is unlikely. There is about a 6% chance. In such patient, first line test is D-dimer test. If D-dimer comes back negative, DVT is excluded. If D-dimer comes back positive, then even if Wells score is less than 2, perform leg Doppler to confirm DVT. So important point to note is that Wells probability score in pulmonary embolism is 4 and in DVT it is 2. So if more than 4 in pulmonary embolism, 4 or more than 4, then pulmonary embolism is likely. And if it is less than 4, then pulmonary embolism is less likely. And in DVT, if Wells score is 2 or more, DVT is likely. And if it is less than 2, then DVT is unlikely. This is a Wells score. You can see all the parameters which you have to look for and how we can calculate a total score. You can read through Wells score by pausing the video. I am not going through all these categories, but you can pause the video and go through Wells score. So this is the end of this video. Hope you find it useful, and please subscribe to my channel, like and share. See you next time with another useful video for PLAB 2 examination. Thank you very much.